Committee on Commerce, Science, and Transportation will come to order. Today we're hearing about what's driving up the price of prescription.
Forward to any questions.
Thank you, Dr. Optebro, and thank you for your work at the University of Washington as well. Dr. Pratt, welcome. Thank you for being here.
Thank you, Committee Chair Cantwell, Ranking Member Cruz, and members of the committee. I appreciate the opportunity to testify on my experience with PBMs. My name is Dr. Deborah Patt, and I serve as a breast cancer specialist in Austin, Texas. I serve in the leadership of Texas Oncology, a large independent community oncology practice, and I'm the Vice President of the Community Oncology Alliance. PBM transparency and accountability is critical because patients being able to get their oral cancer drugs in a timely, effective, and sustainable way allows them to realize the benefits of modern cancer therapy. PBMs steering the filling of these pills to their specialty and mail-order vertically integrated pharmacies all too often results in unnecessary delays, denials, and waste for cancer patients getting potentially life-saving treatments. This is a remarkable time when instead of cancer treatment disrupting how patients live and work, or even being a death sentence, they can enjoy their life with their cancer and control it as a chronic disease, much like hypertension or diabetes. Many Americans with cancer can continue to live in their own lives, work at their jobs, teach at their schools, pick up their kids from soccer practice, and eat dinner at their dinner tables. Oral cancer therapy accounts for about 30% of these therapies today, and we anticipate this will grow to over 60% in the next few years. So this is a large issue and it's growing. The increasing use of these effective but expensive specialty drugs and their profit potential has attracted the top PBMs, with the largest three controlling 80% of the prescription drug market, and adding the next three largest adds to 96% of control. This gives these PBMs who are owned by or own the largest health insurers substantial leverage in controlling what treatment patients get and how and when they get it. PBMs frequently delay and detour appropriate and timely therapy for my patients. The delays and detours are difficult to anticipate and limit a doctor's ability to effectively control the cancer. And delays can lead to poor disease control, morbidity, and mortality for the patients we serve. Doctors frequently modify treatment doses to optimize therapy and control toxicities, sometimes in as little as 1 to 2 weeks after starting a treatment. When a PBM mail-order pharmacy is only willing to fill a 90-day script, supplies of cancer medications, then this can lead to extremely expensive waste, as patients may get 1 to 2 additional months of drugs that they can't ultimately use. I urge you to read my testimony about my patient Tanya, a 40-year-old woman with metastatic breast cancer that now is in her brain. Unfortunately, Tanya was blocked by PBMs and the insurer from getting the medication abemaciclib that I believe is one of the most effective therapies in treating her cancer and her brain metastases. As I saw her cancer metastasize and literally grow on the side of her trunk, I couldn't wait for the PBM and insurer to approve my appeal and had to resort to less effective and more toxic chemotherapy. Since December, Tanya has stopped working. When I saw her last week, we had to deal with 2 new brain metastases we observed on her scans and initiate radiation therapy to address these. I don't know for certain that Tanya would be better off if she had the pills I had prescribed. However, I do know that from the peer-reviewed literature that she would have doubled her chances of living without cancer progression at this time in comparison to the chemotherapy that I had to give her, and that she would have had less toxicity, which would have allowed her to continue to work and live a more normal life, again, which is the dream of modern cancer therapy. Due to the power of the top PBMs, the majority of oral cancer drugs are not filled at our medically integrated pharmacy, but are steered by the PBM to their corporate-affiliated specialty mail-order pharmacy. PBMs will tell you that this is a cost-saving measure, but we don't see evidence that cost savings translates into patient or employer savings. In reality, PBMs control the practice of medicine. In addition, PBMs charge our medically integrated dispensing pharmacies steep DIR fees that are unanticipated expenses that are at a high percentage of total cost and increasing substantially. These are couched as quality measures, but DIR fees are not benchmarks on quality measures that are meaningful to my cancer patients. Things like the STAR rating is often benchmarked on hypertension and cholesterol medication filling. As a breast cancer specialist, you really don't want me controlling your hypertension or cholesterol. So this is problematic and not meaningful to cancer patients. We urgently need PBM transparency and accountability, and this legislation takes necessary steps to get us there. Thank you for your leadership in shining the light of transparency on PBMs. While PBMs operate in the dark, Americans battling cancer and other serious diseases suffer. Thank you for this time, and I'm happy to answer any questions.
Thank you, Dr. Pratt, and best wishes to your patient you mentioned. Thank you for sharing her story. Dr. Trish, welcome.
Great, thank you. Chair Cantwell, Ranking Member Cruz, and other members of the committee, thank you for the opportunity to testify here today. My name is Erin Trish, and I co-direct the Leonard D. Schaefer Center for Health Policy and Economics at the University of Southern California. The Schaefer Center strives to measurably improve value in health through evidence-based policy solutions, research excellence, and public and private sector engagement. As part of this mission, my colleagues and I have been studying prescription drug markets for over a decade. Prescription drug markets are complicated, and it takes a lot of boxes and arrows to show you even a simplified version of how the dollars and goods flow. While that type of complexity keeps health economists like me in business, it still remains a mystery to most Americans. And we know that where there is mystery, there is margin. Pharmacy benefit managers, or PBMs, which operate in the middle of the pharmaceutical supply chain, play an important role in drug pricing. Historically, PBMs were independent from health plans and added value by reducing prices, encouraging uptake of generics, and expanding the use of mail order services. However, a wave of consolidation and other activities in the last few years have distorted behavior. Unfortunately, evidence indicates that PBMs are now leveraging their position to extract profits in ways that are detrimental to patients, payers, and the drug innovation ecosystem more broadly. Perhaps one of the most well-studied issues has been the use of rebates. Rebates drive a wedge between a drug's list price and its net price, or the amount the manufacturer actually receives. Schaefer Center research has shown that for every $1 increase in estimated rebates, list prices increased $1.17 between 2015 and 2018. These rebates have grown considerably over the last decade, distorting the market and raising costs for many patients at the pharmacy counter. The incentives are particularly perverse. Beneficiaries pay the most as a share of the net cost of the drug for drugs that face the most competition, where rebates tend to be largest. The ultimate result of these practices is to decrease the effective generosity of insurance by reducing premiums but increasing out-of-pocket costs. Put another way, this system transfers financial resources from sick patients to healthy premium-paying beneficiaries, the opposite of what insurance is supposed to do. Take insulin, for example. Insulin is a highly competitive drug class with rebates typically greater than 50% of the list price. Nonetheless, many patients face high out-of-pocket costs for insulin precisely because list prices are inflated so PBMs can extract large rebates. Schaefer Center research also demonstrates the importance of following the money. My colleagues found that while total expenditures per unit of insulin remained relatively stable from 2014 to 2018, manufacturers are actually getting paid less year over year. Meanwhile, the share of spending captured by PBMs increased 155% over that 5-year period. At this point, less than half of each dollar spent on insulin goes to the manufacturers. Instead, the majority gets siphoned away by distribution system intermediaries, a parasitic loss, if you will. Other examples abound. For one, a 2018 Schaefer Center study found that 23% of prescriptions involved a patient copayment that exceeded the cost of the prescription to the PBM, or a so-called copay clawback. That is, the patient paid too much and the PBM kept the difference. Another, investigations and lawsuits in recent years have illuminated the pervasive practice of spread pricing, where PBMs charge health plans and payers more for a given transaction than what they reimburse to the pharmacy, keeping the spread or difference. For example, a 2018 Ohio auditor report found that PBMs charged the state a spread of more than 31% for generic drugs for its Medicaid plans. And another, in 2020, PBMs extracted $9.5 billion in price concessions, the type we've heard about from the previous two witnesses, from pharmacies on Medicare Part D transactions alone, up over 1,000% from a decade prior. These issues might be less concerning if we believed our current system of pharmaceutical distribution and reimbursement, centered on and orchestrated by PBMs, was working efficiently. Unfortunately, evidence suggests that it is not. When my colleagues and I compared cash prices for common generic drugs at Costco With their cost to the Medicare system, we found that Medicare overpaid on 43% of prescriptions in 2018, totaling $2.6 billion in overspending for the program in that year alone. It is clear that reforms are needed to improve the functioning of the pharmaceutical distribution system and ensure that the system works to benefit patients and drive value. These could include things like increasing transparency, prohibiting tactics that feed off the current complexity, and further investigation to better understand the myriad ways the current system harms consumers and reduces innovation. Thank you, and I look forward to your questions.
Thank you very much, Dr. Trish. Thank you in general for your work. Dr. Mulligan.
Good morning, Chairman Cantwell and Ranking Member Cruz and members of the committee. Thank you for this opportunity to comment on the economics of pharmacy benefit management. Prescription drugs greatly contribute to public health, but they're expensive to develop, which brings economics front and center. Drug insurance plans understand that it is wasteful, namely requiring premiums that are too high to attract members to have third-party payment and leave the benefit unmanaged. Benefit management is fundamentally an economic activity involving plan design such as allocating drugs to different copay tiers, drug utilization reviews that help improve drug effectiveness, obtaining rebates and discounts from those providers whose sales are increased by the plan. Group purchasing and negotiated discounts are even more valuable when manufacturers and pharmacy companies are monopolistic or oligopolistic. Buyers clubs can and do take a small amount of competition among sellers and magnify it. Naturally, they benefit buyers, but it is not a zero-sum game. Buyers clubs benefit buyers more than they cost sellers, and sometimes benefit sellers too. Group purchasing and negotiated discounts are tools familiar from buyers clubs such as Costco and Sam's Club. Costco members may not have a particularly price-sensitive demand for specific brands of, say, skateboards, but skateboard manufacturers, if they dealt with them individually, would hike their prices. But Costco limits who can sell to their members to those pricing the lowest. Sellers' best response in this situation is to steeply discount and partly make up on volume. Lower prices and higher quantities are the proof that buyers clubs are pro-competitive. PBMs are buyers clubs for members of multiple drug plans. Much like Costco excludes skateboard manufacturers, PBMs can place a manufacturer's products to incentivize discounts for consumers. Any buyers club requires resources. These costs limit the scope and degree of involvement of buyers clubs in the economy. Costco and PBMs have innovated to become more productive and thereby expand their contribution. Keenly aware of the common economics, Costco itself has gotten hugely into the business, purchasing, I believe, 3 PBMs of different types. Regulation is likely to be the opposite of this process by raising management costs and reducing discounts received by members of health insurance plans. Indeed, drug plans and their PBM agents have done a remarkable job at getting prescriptions to the patients who need them. Studies repeatedly show that drug utilization is essentially as high before patent expiration as it is after, even though the cheaper generics are available only after expiration. PBMs and plans also do the advanced financials for unique new drugs under development so that plan members can get access as soon as possible after FDA approval. Sadly, European patients do not have PBMs working for them, and they are treated with less effective, older generation oncology and other drugs. With the federal government as a partner in paying premiums and medical procedures that can result from poor adherence, PBMs help taxpayers too, and thereby the wider economy. I estimate that benefit management expands the economic pie more than $145 billion per year. The other side of the coin is that manufacturers and pharmacy companies may push for regulations to restrict the activities of buyers clubs. I estimate that a variety of such regulations benefit manufacturers and pharmacy companies to some degree, but at greater cost to patients, plans, and taxpayers because the regulations forego part of that $145 billion. In the likely case that large incumbent PBMs better adapt to regulation than smaller new ones do, another unintended consequence would be reduced competition, namely growing the big PBMs at the expense of the little ones. Section 2 of today's bill gives PBMs 2 compliance options, one requiring them to publicly disclose their remuneration, and the other prohibiting pharmacy discounts that are obtained, quote, arbitrarily, unfairly, or deceptively. How will Ms. Chairman Khan interpret those words? I don't know. So I worked out a few different scenarios. One scenario involves significant costs to protect pharmacy companies from competition, adding between 8 and 11 billion annually to the federal deficit. Another scenario is dominated by the mandatory disclosures that, as DOJ, FTC, and others have warned, may undermine competition among manufacturers and among pharmacies and among PBMs. The annual net cost of reducing just manufacturer competition could easily exceed $25 billion annually and add $20 billion annually to the federal deficit. Also, reducing pharmacy and PBM competition could potentially bring the total addition to the deficit of $40 billion annually. Thank you, and I welcome your questions.
Thank you very much. I'm reminded this morning of a time when we had a similar issue, derivatives, and one of our colleagues on the Senate floor said, "We can't regulate derivatives, we don't understand them." And then shortly thereafter, our whole US economy blew up. So I guarantee you, we can look at this market and we can understand what's going on, and we certainly can benefit from more transparency. Since I served on the Judiciary Committee for a short period of time and then started this work on Senator Grassley, we were able, in the Affordable Care Act, to give CMS and the Department of Justice the ability to look at these numbers without disclosing them. And it's that kind of policing in the market that we expect people to do so that consumers, from the vertical integration that's happened, don't suffer from the concentration. So I love the Costco model. In fact, I'm trying to drive it into some other healthcare decision making, because if you buy in bulk, yes, you should get a discount. The question here is, who is getting the discount? Is the consumer getting the discount, or the very manufacturers who own the PBMs getting the discount and pocketing it? And when we looked at this issue when it was Merck Medco, that's exactly what was happening. People were negotiating with King County and a union, just like you discussed, and saying, okay, we negotiated a 35% discount. They gave the union 5% of the discount, and the company and the drug manufacturer pocketed the 35%. The very people who owned the drug. So these are the practices that are driving Americans crazy, and they want some transparency. So I want to go back to you, Dr. Trish, since you're the resident expert here on the long study of this. What has changed? All the witnesses mentioned the vertical integration. So what's happened here is fewer people own the ability to create competition and buy the price. So I want you to explain what's changed over the last decade about that has allowed this concentration of power. And then if you could also explain why this discount isn't being passed on, and why now it's squeezing Dr. Optibro, because he has no recourse. He's a buyer, he's buying the drugs, but then he's not getting reimbursed for the price of the drug. So that's what's going on here. So why is this market power and concentration been accelerated over the last whatever period of time it is? I'm saying it's 10 years, but maybe it's shorter or longer, I don't know.
Absolutely. So if you look at the history, what we've seen is a considerable degree of integration in this industry, where PBMs are no longer freestanding entities, but instead all of the three biggest PBMs are integrated or owned by a health plan, a health insurer. Many of them also own or have a footprint in the pharmacy market, or at least in the specialty pharmacy market, and some in the healthcare provider market as well. And so that is now an entrenched set of incentives where they can, have an incentive to essentially steer funds to themselves, preferentially over to other independent pharmacies or other examples like that. So if you look at a world where, there are certainly examples where vertical integration can improve the way that markets function, but it also raises questions about incentives, right? And so if you're a PBM that is integrated or affiliated or owned by a health insurer, and you're thinking about, do I want to preferentially have my contract benefit my health insurer relative to the other health insurers in the market? That's the type of question that we need to better study. Likewise, if you own the pharmacy or a set of pharmacies and you want to have more favorable reimbursement terms to the pharmacies that you own or that are affiliated with, or steer the business there, that can harm the independent pharmacies that are not affiliated. And that's exactly the type of contract structure that we need more insight into to understand how this is playing out in the market.
I definitely don't want a concentration of power. There are some, and there's some who are even these companies who don't even want, they just want all mail order. That's what they want. And I can tell you, I believe in the pharmacist. I believe in the interaction that they have with the patient. I believe that it's a consult that's valuable to keep in our community. So, but that aside, it's the consumer who's not getting the discount. If you're buying on my behalf, whether it's a plan for, you know, the U.S. government, a county, or a business, I'm hearing complaints now from big businesses in my state who are saying, these people are cornering the market. It's affecting big employer plans because they're doing the same thing. They have that much concentration of power. So we have no transparency onto what discount. Do you have any idea what kind of discounts are being driven? Do you have an idea about what percentages?
So what we do know, I can tell from the work that, especially in the insulin space where there's a bit more transparency thanks to some of the state efforts and other things that have happened, what we have seen is that over time, PBMs have in fact been effective at lowering the net prices that those insulin manufacturers are receiving. But that, as you just described, is not the price that we as people or patients actually care about. What we care about is how much we are spending on these products. And the research that we've done has shown that that's roughly been flat over time. But what's happening is the share of those dollars that are going to the supply chain have increased rather than the dollars that are going to the manufacturers. But you're right that the consumers themselves aren't benefiting.
Thank you. Senator Cruz.
Thank you, Madam Chair. Welcome to each of the witnesses. Thank you for being here. Dr. Pat, always good to see a fellow Texan. Welcome to D.C. I'll note Chairwoman Cantwell observed that all four of our witnesses are doctors. Reminds me of the scene from the classic comedy Spies Like Us, doctor, 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 doctor. So welcome, doctors. Dr. Mulligan, no one wants higher drug prices. And I think we need to look for creative solutions to lower them. But with every legislative solution, we got to consider the trade-offs, especially when our solution is to grant additional authority to a government agency to regulate in a particular market. Government regulation can create substantial compliance costs. It can also create barriers to entry for competitors in a market. This bill imposes both contractual disclosure requirements, meaning it tells PBMs they must share data on how much they pay providers and manufacturers for each drugs, and it also prohibits things like clawbacks and spread pricing. Dr. Mulligan, one argument for the bill is that there's too much consolidation among PBMs right now. We've heard that argument made this morning. In your analysis of the bill, could the bill's requirement lead to more or less market consolidation of PBMs? Please turn your microphone on.
It could lead to more. We doctors maybe should try not to do no harm. The regulations generally, they disproportionately burden the small businesses, and this bill doesn't have any exemption for smaller businesses. And the vertical integration that's been described is especially problematic with respect to this bill because the requirements are going to be telling the bigger PBMs, how much does your left hand pay your right hand? Well, they could just answer that any way that pleases the FTC. It doesn't really matter. What's going to matter is for the smaller companies.
So I want to follow up on the question. So you're saying it would be beneficial if you want to avoid market consolidation for the bill to have some sort of exemption for smaller PBMs. Is that?
It'd be better not to have the bill, but the bill with an exemption for smaller businesses, like we do so with so many other regulations, would be an improvement.
Okay, that's helpful. If this bill was enacted into law, based on your economic analysis, how would it impact drug prices for the average American?
300 million plus Americans are in insurance, and insurance companies, they are the benefit managers, or they hire people to do the benefit management for them, and that's what they want. They want lower prices and better utilization. And you're undermining that activity, and so drug prices will go up. I estimate just the pharmacy part alone could add to premiums about $10 billion a year in aggregate.
So explain how that is for someone at home who's watching this. Look, we've all been in a situation where you're paying too much, you're frustrated, you're dealing with the bureaucracy, and it pisses you off. Explain what you believe would be the negative consequences of this bill for a consumer at home that wants high-quality health care, high-quality pharmaceuticals at an affordable price. If I understand you correctly, you're concerned this bill would be counterproductive for that.
That's right. We have pharmacy companies and manufacturers who have market power. And the best way consumers will be able to deal with that is to join these buyers clubs, like they do with Costco. And now you're going to undermine the one tool they've had to try to create some competition in that space by burdening the very companies whose job it is and who have successfully gotten lower prices for the consumers.
So if you're correct that this bill would hurt patients by driving up costs, typically when one group is being hurt in the economy, somebody else is doing better. So if consumers would lose money, who would get the money? Who makes out well under this bill?
Well, it's not a zero-sum game, so the winners actually gain less than the losers from this bill. But the winners are the manufacturers. There'll be less competition among manufacturers.
So like Big Pharma?
Big Pharma and the pharmacy companies.
So your testimony is this bill benefits Big Pharma and allows them to make more money. Is that right?
Yes, and the report I put in the record has a numerical estimate to that effect, yes.
And based on your analysis of the legislation, what do you calculate would be the additional cost to the federal government if this bill passed?
I still have to see how Chairwoman Khan interprets some of these words in the bill, but easily $10 billion a year to the federal deficit, maybe $40 billion a year, maybe more.
So over 10 years, you're talking somewhere between $100 billion to $400 billion in cost to the taxpayers?
Yes, it's in the ballpark of that rebate rule that was scored by OACT and CBO.
Wow. Okay, thank you, sir.
Senator Welch. Oh, okay.
Thank you very much. Where is it? Thank you. I want to talk about the impact of PBMs. We have a real crisis in Vermont with the pressure on local pharmacies. And my view, local pharmacies are absolutely essential to the delivery of quality health care. My experience, and it includes personal experience, a physician will give you a prescription, and everybody's prescription is not necessarily how it ultimately has to be. And the capacity of a patient to go into a local pharmacy where there's some trust and knowledge and have that physician be, or pardon me, that local pharmacist be able to essentially talk through what some of the reactions are and help that person get the medication utilization that is actually the maximum benefit is really essential to the well-being of the patient. And we've got a healthcare system that is just crushing primary delivery people in it, and they're the most essential in it. And the local pharmacies with the PBMs are having inflicted on them something that's truly astonishing in a capitalist economy, and that is they are allowed to sell it at price X, and 3 months later they get a clawback saying you owe us money. How in the world is that fair? Seriously, how in the world is that fair? And it's not just that it's a ripoff for the local pharmacist, it's crushing the capacity of those folks who care about the people in their community to be able to help the fellow citizens in their community, and it's just flat out wrong. So Senator Tester and I are working on something to try to protect our local pharmacies, and that's because we think those people are doing work that the folks we represent really, really need. So I'll ask each of you, how do we end this clawback? It's totally, completely unjustified and unfair. And we'll just go down the line and people can tell me, you for it or you against it?
Well, thank you, Senator Welch. as an independent pharmacist, I am against it because it's causing real harm. These fees are totally unpredictable and make it completely impossible to run a sustainable business.
Right. Just let other people do it. But thank you for your good work.
I concur. I think that DIR fees are not meaningful measures of quality. They've grown from around 7 years ago, 4% of total costs, to over 11% of total costs in our pharmacy today, and they're not anchored on any measure of quality. So if they were truly quality clawbacks, then I think that it would make sense. But again, in my practice, it would measure things like, have you had your hypertensive medications filled by our pharmacy? Have you had your cholesterol medications filled? And have you filled your oral oncolytics every 30 days?
You're giving me a headache. You have to deal with that?
So as a cancer specialist, frequently I hold medication because of toxicity to make sure patients can remain adherent and benefit from therapy. So I would say actually they facilitate poorer quality in the patients we serve, and they're anchored on unmeaningful measures. The other thing is, I think that you can't just say DIR fees go away and it has one effect on the economics of the healthcare ecosystem, because what happens is wholesale acquisition cost changes as DIR fees change, and so we would anticipate that the market reacts. But DIR fees clearly are not a measure of quality, and they diminish the ability for pharmacists to do meaningful work.
Thank you very much.
Thank you. I'm a health economist, but sit in the School of Pharmacy at USC, so very much appreciate and have had firsthand experience of the important role that pharmacists play in our healthcare system. I think, I actually agree with Professor Mulligan that PBMs do need tools to effectively negotiate, right? That we do want our healthcare system to reflect the value of those negotiations. But when that happens in a highly opaque and complex market where PBMs are the one holding the information and initiating many of these fees after the fact in somewhat arbitrary or confusing or in ways that, as we just heard, don't necessarily even reflect value, that's a concern and that's a problem.
Thank you. Thank you very much.
I'm a technocrat.
My time is
Technocrats are the last ones that should be asked to what policy should be. We can tell you about the trade-offs and electric officials. Now, I'll remind you some of the trade-offs, and we practice this in the executive branch, that you're talking about regulating contracts, price controls. These can have side effects, unintended consequences that are pretty bad, and so at least we need to do the due diligence around what the trade-offs are. And one of the trade-offs are, if you're going to regulate contracts between pharmacies and other businesses, then that means that those businesses are going to tend to merge, and you're going to tend to have, as Senator Cruz and I were discussing, you'll tend to favor the big guys.
Dr. Mulligan, we have to move on, but I will send Senator Grassley to talk to you about that, because I'm pretty sure he doesn't agree with your interpretation. Neither do I, but I think more importantly, let's have him talk to you why he wanted the legislation designed this way. We don't think it's setting a price. It's taking activities that we think are unlawful in how they're acting. No one who thinks spread pricing or clawbacks are the way to make the market function. Okay, we are to Senator let's see. Senator Budd is here. Senator Budd.
I thank the chair. So I've heard directly from patients in North Carolina. They can't afford the medications that they need. The cost of drugs covered by Medicare grew at a rate faster than inflation. It's serious for families that are struggling to keep up with the rising cost of grocery, utilities, seniors living on fixed incomes. So pharmacy benefit managers were created to negotiate drug prices and address these costs. There are concerns that patients aren't seeing the savings that get negotiated. Now, the healthcare industry is complex. We need to examine what is causing this cost increase and consider ways to bring more transparency to the drug supply chain. So Dr. Oftebro, you discussed how PBMs retroactively claw back fees and reimbursement dollars from a pharmacy after a patient picks up a prescription and the pharmacy has paid for its service. Now, can you explain how this impacts your ability to provide care to patients?
Well, we have to close our pharmacies.
Can you talk a little bit about the basic economics that lead to that?
We have in whether or not negotiation in these contracts, when we're presented with these fees, they are clawed back, and it impacts our operating budget. We're not able to hire staff. We can't afford to have pharmacists to provide these additional services, and we ultimately need to close our doors.
You share that the vertical integration in the drug supply chain creates conflicts of interest. I think massive conflicts of interest is what you said. Can you expand on how that creates that conflict of interest?
Yes. One of our other pharmacy practices in downtown Seattle serves a large population of patients living with HIV. We dispense a lot of HIV medications. One of the large PBMs sent us a letter and said that they were going to move all of the HIV medications into a specialty category, and that if we wanted to continue to be able to dispense these medications, we would need to accreditation PBM, which is the entity sign a direct PBM before they would such a crucial service to a vulnerable patient population. We had no choice. And when we received that contract, it was significantly lower reimbursing contract. We lose hundreds of dollars on every fill of these HIV medications that they would prefer to steer into their own specialty pharmacy. There's a study out of the state of Florida by 3 Axis Advisors that demonstrates that in those situations, those PBM-owned specialty pharmacies are actually charging more for those medications than when they're paid for in the independent pharmacies.
Thank you. Dr. Trish, you mentioned in your written testimony that there's evidence to suggest that PBMs favor high list price drugs, but you also noted that this is hard to prove definitively without access to rebate data. Could you share more about what additional data is needed to complete the picture and whether that data is proprietary?
Yes, absolutely. So it just, these are part of the example in the position where it is the case to negotiate networks, and we have the same dynamic where you're trying to essentially extract a lower price in exchange for an expectation of higher volume. In that world, we know what those prices are, right? When I pay my cost sharing, it's based off that negotiated price, not what the hospital is charging, but the actual negotiated price. And we know that the amount that the health insurer is paying to the physician is the same as what they're turning around and charging to the employer, right? That there's no spread or difference there. In the PBM world, it's the opposite. All of that is kept in secrecy and is very complex and very hard to understand the way that this is actually playing out.
Thank you, and my time is short, but Dr. Mulligan, yes or no, do you think that adding rebate data to the analysis of rising drug costs would be tapping into proprietary information?
Yes.
Thank you. So I appreciate you all taking time to share your insights, and I look forward to continue to examine rising drug prices and thank you.
And I want to thank you and the drug prices. But what I see them do, I don't think the consumer gets much benefit, and they're shutting down small businesses on Main Street right and left, and those are called our local neighborhood pharmacies. So as far as holding the big pharmaceutical companies accountable, I don't see it. And the reason I don't see it is because there is no transparency in PBMs. None, zero, nada, kaput, nothing. And quite frankly, when you combine that with anti-competitive tactics, this is a recipe where the only people that win in healthcare costs are the PBMs. So, Mr. Ofterbro, tactics that PBM These small pharmacies like yours, like the one we have in my hometown, population 600, and how they're pushing you out of their network and limiting your abilities as a rural community provider.
Thanks, Senator Tester. Yes, as I stated earlier, we see every day patient steering, whether it's the use of the specialty category of medications that will steer patients into PBM-owned mail-order pharmacies, mandatory mail-order practices, just the way that we're forced to contract with PBMs, where we have absolutely zero negotiating power. These are take it or leave it contracts, and the terms and conditions are totally unbearable. The fees that I described, both the DIR and the GER and the ones that they haven't even invented yet, they're impossible to predict, and it makes it impossible to provide the level of care that our communities deserve.
Do you have any sort of numbers or metrics on how much of the drugs that go out your shop's doors are drugs that are impacted by PBMs?
Virtually all of them.
Okay. So you get these practices, and know fully well any small business or any business, no matter what it is, if you don't turn a profit, you don't stay open. And would it be fair to say they're squeezing you to the point where your profitability is to a point where you're going to have to close your doors if we don't do something in Congress about this?
In 2022, we closed our pharmacy in the Eastlake neighborhood of Seattle. It's the only pharmacy in the neighborhood, and we closed it precisely because of these retroactive fees.
I'm going to stay with you. Spread pricing. I'm interested when charging for a common generic drug, antibiotics, yeah, the list is long. Let's say we have a little pharmacy in Big Sandy, Montana, and the PBM reimburses a diabetes medication for $10. How much does the PBM then charge the insurer, could you say? So they're paying you $10.
They're paying us.
What are they charging on the other side?
I have no idea.
Generics.
I have no idea.
Okay. Would new transparency requirements, if they were implemented the way this bill intends, do you think that would put unduly burdens on you as an independent pharmacy?
Would PBM transparency put a burden on small pharmacies?
Yes, correct.
I don't believe it would put any burden on us unless, of course, the PBM uses it as a reason to extract more from pharmacies.
Which is my next question. Do you think more transparency would make medications more profitable for the patient or less?
It should make it less cost to the patient.
I've got to tell you, as these were first set up, I'm sure they were set up for the best of reasons. But anytime you have a situation where these guys can go do what they want, and a lot of the big PBMs are owned by insurance companies, I don't see where the patient's getting the benefit. In fact, I see where these PBMs have a tremendous potential for further drying up rural America, and we need to be focused on a lot of these rural areas when it comes to healthcare, because it's not like driving 2 blocks down the street to see your doctor. It's more like driving 65 or 100 miles one way to see that doc. And it's the same thing with small pharmacies. If you don't have one in your town, and we didn't have one in our town for a while, it makes healthcare much more complicated. Thank you, Madam Chair.
Thank you, Senator Tester. Senator Capito.
Thank you, Madam Chair, and thank you all for being here today, this very important hearing. So as I sit here and listen to this, and I voted for the bill when it came through committee last year, I believe, a couple things come to mind. So this is what would have been really helpful, I think, for everybody to bring: a flow chart that starts from the research of the drug to the person who actually gets it and what they pay for. So I made a little list myself. You've got the research, the manufacturing, the distributor, the PBM, the insurer, the doctor or hospital, the pharmacy, and then it gets to the patient. And I guarantee you, looking at a flow chart, if we actually had that in front of us, it would be more difficult to read than a flow chart from the Corps of Engineers. Because it would be if this, that, and before you know it, total confusion, which is what I think we have in terms of the lack of transparency with PBMs. You know, the old saying, I can't remember what the movie was, and Senator Cruz will know because I think he's a movie aficionado, follow the money. This is what the flow chart would also show us, follow the money. What movie is that?
That'd be All the President's Men.
I thought it was the one with Tom Cruise. Anyway, so much for that. So my question is to Dr. Oftbro, and you've answered several of the questions that I already have. I know that, have you ever had success in amending or negotiating a contract to alleviate some of these issues? I think you answered that, but if you could repeat your answer there, please.
We've made multiple attempts to try and negotiate better terms on contracts, and we have yet to be successful.
Did I accurately portray in your mind what a flow chart might look like? How would you respond to that if you had to bring a flow chart here?
No, I think what you described was not complicated enough.
Okay. I know a few states, my state of West Virginia being one, you mentioned in your hearing I hope I say this right, rosuvastatin, and that you had talked about the impacts of that and PBMs on that. Is this something that's unique to you, or is this occurring all across the country?
Well, this was a large national Medicare Part D plan. It's happening in every pharmacy in the country. And it wasn't just this one drug. It happens with many, many drugs every day for all kinds of plans.
Okay. Also, I note that West Virginia has passed a number of bills trying to get at some of these issues. I mean, the last thing is probably a patchwork issue that we need because of a lot of complications with mail order and other things. Has Washington State attempted to pass similar laws to help you out here?
We have passed some legislation, and we're working on additional legislation right now.
Has it been helpful?
The biggest challenge that we've had in Washington State is that our existing legislation has exempted ERISA plans, so self-insured plans, and so our existing existing laws only cover about 10 to 20% of the prescriptions that we dispense.
So yeah, on my flow chart on insurers, I'd have to have a couple little buckets over there because of all the different things. Dr. Trish, last question. You talk about the historic role that PBMs have played in lowering costs. Obviously, Senator Tester said that was the first goal. But you say over the last decade that this situation has deteriorated. What do you believe has caused this shift? Is it the consolidations?
I do think, part of it has been the consolidation and integration. I think what we see now is that CVS Health and United Health Group are actually the 4th and 5th biggest companies by revenue on top of the Fortune 100 in the U.S. And Cigna or Express Scripts or Evernorth, I think, is number 12 now. I mean, these are pretty significant companies here in the U.S. I think we've also continued to see that the market has gotten increasingly complex, and that makes it harder and harder to understand and enables more opportunities for this type of arbitrage and kind of deceptive practices.
Okay, so then, last thought, put yourself in the shoes of the person going to the counter to try to purchase a much-needed drug. And I think we shouldn't lose sight in any hearing such as this as the magnificence of our pharmaceutical industry in terms of curing and also managing diseases. That is something that is phenomenal for all of us. And how's anybody supposed to know? I mean, if they went to Dr. I want to not pronounce it, Oftbro's pharmacy, and then went to another pharmacy in West Virginia, they could pay totally different. They could pay different prices. It's just I think it is the confusion masks where the money's going, and I think in the end, the intent is to get it to that person at the counter. Thank you all very much.
Thank you. Senator Sullivan.
Thank you, Madam Chair, and I want to thank the witnesses here. I think the themes are starting to emerge from this hearing, which aren't terribly surprising. From Alaska's perspective, we've had several Alaskan-owned independent pharmacies that have gone out of business over the last several years. Obviously, it's happening all over the country. And the issue of the lack of transparency seems to be front and center. Anchorage right now, our largest city, my hometown, only has one independent pharmacy left. That's Bernie's Pharmacy, run by a great Alaskan named Teresa Hall, who's doing a great job trying to serve local Alaskans. In Sitka, we don't have a Walgreens or a CVS. We do have an Alaska family-owned independent pharmacy. The White family runs that. They do a great job, but I hear about their struggles. The numbers are pretty dramatic here. According to a 2022 report from the National Association of Insurance Commissioners, there are 66 PBM companies, with the three largest, Express Scripts, CVS Care, and Optimum RX, controlling more than 80% of the market and serving 270 million Americans. That is some serious market power. This is the opposite of small business. So what I wanted to ask each of the panelists, two questions, and you can take them in order. I'll just let all of you respond. One is transparency. The bill that we're talking about today, is it the right amount of transparency? Are there other things we can do with regard to transparency for PBMs? I think that is a really obvious starting point, but how deep do we need to go on that? And what are we missing on that idea of transparency that may or may not be in this bill? And then secondly, this is a little bit more current, but I want you to kind of look at the current situation. I have concerns about the current situation. But structurally, is the FTC the correct avenue to address this transparency issue? Are there other agencies we should be looking at? I'm starting to have increasing concerns about the leadership at the FTC. I did not vote for the chair, Linda Kahn. There was a Wall Street Journal article just recently, the last Republican commissioner on the FTC is resigning, and she's doing so in part because she said, quote, Kahn's willful disregard of congressionally imposed limits on agency jurisdiction, defiance of legal precedent, abuse of power. So I'm getting a little nervous about the FTC, both currently with the leadership, but also, is it structurally the right federal agency to be taking a look at the transparency issues? And that, I think that is what the law that we're looking at proposes. So both those questions, I'll open up to all the witnesses.
Thank you, Senator. And I'd like to say that Bernie Claudio was a dear friend and mentor of mine.
Oh, good.
Yeah.
Well, they do great work, but they're, it's tough. And that's, that's our big city, Anchorage, right?
Yeah.
And they're it in Anchorage.
They are it. To answer your first question about, is this the right amount of transparency? I don't know yet the answer to that question. But what I do know is that what we have now is not working.
Yeah.
And we want to see PBMs regulated the same way that everybody else in healthcare is regulated.
Do you have a view on the FTC?
I think my answer is the same, but what I can tell you is that, from our perspective, we're seeing unfair and anti-competitive business practices in terms of our interactions with PBMs, and
Okay.
I think that's how I don't know who else would help us deal with that.
Any other witnesses on both the transparency question or the FTC question?
So to the first question about transparency, I do think that this is really important, probably the most important piece of legislation to deal with the issue, to bring light to many of the other problems. There are other issues, copay accumulators, HR 830, gag clauses, fail first step therapy, and other things. So there are other problems, but as you deal with PBMs, I frequently feel like it's a game of whack-a-mole, and transparency, I think, sheds light on many of the other challenges that is the best way and most comprehensive way to move forward to make meaningful change. The second issue of jurisdiction, I don't know.
I think also on the transparency and the scope, I think another sort of perhaps less appreciated actor in this market has been the role of the benefits consultants or the people who are trying to help employers navigate this and pick what PBM contract they should be signing. In many cases, those benefit consultants are not playing a fiduciary role for the employer, but are actually being compensated by the PBMs as well. And so to look at, even if the supposed brokers of information here are being incentivized in ways that are detrimental to the system as well. I'll just say on the second, there's also the GAO, there's also other agencies that can be involved in this too. I think, to the extent that there are issues at the FTC, that needs to be addressed more broadly, right? Obviously for many reasons.
Any views on that?
I would point you to the references in my testimony. FTC, DOJ, and others are very concerned about the effects of the transparency, particularly the way it's laid on Section 2, way too granular. It was with any regulation as an economist, I like to be able to see the law have clearly defined terms, and there's a lot of terms that the administrative state is going to be able to interpret. And I share the concerns that the FTC we have now would reinvent the lexicon, to be frank.
Thank you. Thank you, Madam Chair.
Thank you. Senator Blackburn.
Thank you, Madam Chairman, and thank you, each of you, for being here today. It is wonderful to hear from you on your perspective about what is going on. The FTC, with the work that they are doing, also looking at the vertical integration, and the access to different patient pharmaceuticals. And let's see, Dr. Pat and Dr. Offbro, I wanted to ask you about access to specific pharmaceuticals for patients and how the PBMs affect that and the choices that they are making, and how often are you how often do you see this as a problem for patients getting precisely what they need for the period of time that they need it?
Thank you, Senator. And I'll say I work closely with Dr. Patton and Dr. Schleicher from Tennessee Oncology and the Community Oncology Alliance, so they're well familiar with these issues. We frequently see that PBMs in their insurance vertically integrated partnerships determine which therapies can be given first. I think a great example of that is in breast cancer, when I want to treat a patient with a class of drugs called a CDK4/6 inhibitor. There are 3 drugs that are approved on the market, and I might choose one because of very specific patient issues. One has better evidence for brain metastasis, one is not as good as if the patient has diarrhea, and I'm frequently not able to make those choices based on what's best for the patient because of direction and formulary restriction on the part of the PBM. In addition to that, frequently the PBM makes preferential choices that might be more expensive for the patient. So my colleague, Miriam Atkins, who practices out of Augusta, Georgia, prescribed imatinib for her patient with GI stromal tumor. The patient out-of-pocket cost was going to be $1,500 if run through insurance because of the way that they contracted with the brand name drug. But whenever they didn't apply it to insurance, and the patient wasn't going to take their medication, they were just not going to treat their metastatic cancer. Instead, they just sold it and ran it out of their office, and they were able to get it for about $150, and they were able to take the medication. So it shouldn't be the case that patients have more options by not using the insurance that they pay for. And these are some of the pivots that we're directed to because of PBM management.
Well, thank you for that, and thank you for mentioning Tennessee Oncology and the great work that they do there. We appreciate what they do in our community. Dr. Oberstdorf?
Thank you, Senator. I would echo, we see the exact same issues in community pharmacy when patients and providers are restricted in their formulary choices, and one medication might be more appropriate, but it's not available to the patient. The other thing that we see quite a bit of is mandatory mail order, and it may be mandatory mail order in general or for specific medications that pharmacy benefit managers have deemed as specialty. And there may not be any clinical rationale for a medication being designated as specialty. It's just in the PBM's economic benefit to categorize it as a specialty medication. And when those medications aren't available to patients to access through the community pharmacy, that can lead to gaps in therapy. We've had this happen with patients in our PrEP clinic. We run a pharmacist-run clinic for patients who are to prevent HIV, and this requires labs and then daily medication. And when they go without that medication because it doesn't show up in time in the mail, they have to restart all of that lab work. It's additional cost to the Medicaid program and the health insurers.
So listening to the two of you, PBMs actually get in the way and prohibit proper care. Let me ask each of you, if given the choice, would you completely eliminate PBMs?
I think all that we're looking for is to see that PBMs are regulated in the same way that the rest of us are as healthcare providers. They're a part of the healthcare system. They need to be regulated, and we need a fair landscape.
Okay, Dr. Pat?
It's so tempting to say that I would completely eliminate PBMs, but the truth is I don't know that that's the right answer. I think it would improve upon things currently. I will say that I take issue with the analogy of PBMs being like group purchasing like you would see with a Costco, because I think that analogy only holds if Costco is the only place that you can shop. Because the challenge is that discounts that PBMs negotiate may not be translated to employers and patients. In fact, we don't see evidence that it is. In contrast to the Costco analogy, where shoppers have the ability of choice, we don't act like that in healthcare. So it's a limited analogy, and while PBMs might purchase at discounts, we need to see evidence of where those discounts are going. And I suspect that they're not going to patients and employers. At least when I talk to patients and employers, we don't see any evidence of that.
I'm yet to find a patient who says a PBM has saved them money. I have found many patients who tell me the PBM would not allow them to have what the doctor prescribed. Thank you so much for being here for our hearing today. Thank you, Madam Chairman.
Colorado.
Thank you, Mr. Chair. I want to start, first I want to thank you all for being here and appreciate how busy you are and taking the time out to come and answer our questions. You do add real value and perspective. Dr. Trish, the Schaefer Center found that for every $1 Americans spend on insulin, less than half ultimately goes to the manufacturer. Instead, that money gets rerouted and taken by middlemen along the way, like PBMs. All the while, the list continues to grow. The list continues to go up, even on drugs like insulin that have been around for more than 100 years. I think that's really at the heart of why we need transparency. Where is the money going? Why are we paying so much? So, Dr. Trish, you mentioned that transparency is a key, but further investigation is needed to truly understand how to reform the system and protect patients. What other areas do you believe need to be investigated?
So thank you for the question. I think, one of the key other issues here is the extent to which this integration has changed the incentives. And I had the good fortune the other day of giving a talk at a health system where I had both the chief pharmacy officer and the HR person for the health system in the room. They were talking about this issue that we heard about, this report in Florida, but essentially because they're a health system, they own a specialty pharmacy, right? They dispense drugs to their patients. They were saying that their PBM for their beneficiaries is basically requiring them to use the in-house specialty pharmacy that's owned by the PBM, even though they can see that specialty pharmacy that's owned by the PBM is charging them more than 3 times more for the drugs than what they dispense in their specialty pharmacy themselves. And those are the types of things where that's harmful, that's not generating value. The extent to which that's also further affecting the types of rebate negotiations across drugs more broadly, that's what we need better insight into as well.
Right. Well, certainly in a lot of what you're describing, we see throughout healthcare, which is the the lack of mission. When I was a kid, and that's pretty long ago, doctors, nurses, pretty much everyone you met in a hospital or a medical center was there because they wanted to help bring reliable health care at the lowest possible cost to the people of their community. And somehow we've lost that. Dr. Pat, more often than not, consumers do not have the necessary information available to them about how much their drugs cost. Much less information about the role of PBMs, drug manufacturers, insurance companies, ad infinitum, that help each other raise prices. I think additional transparency clearly is important, but we must make sure that the information actually reaches the patients. So Dr. Pat, do you often find that your patients struggle to navigate the system? Does that come back to you? How can we make sure that PBMs provide the information in an accessible and easy to understand format without layering it under, portals and portals and portals?
It's a great question, and I'll say work closely with the Rocky Mountain Cancer Center doctors, so I'm grateful for your question. I think that we need to give more information to patients because frequently the cost of drugs prohibits patients from being compliant with care. I gave the example of the patient with imatinib that if they'd run it through their insurance, their copay would have been $1,500 per month, and whenever they didn't go through insurance, it was going to be just $150 a month at the practice. Well, if the doctor and the pharmacist didn't have an ability to have that discourse with the patient would have just not taken the medication and not benefited from the medication. We know from a study published in the Journal of Clinical Oncology in 2017 that patient adherence to their medication is directly related to their copay that they have to pay every month. And if it's cost prohibitive for patients, they are not going to be compliant. They ration their medication. We've seen that time and time again. So that leads to ineffective care. So when you have pharmacists and medically integrated pharmacies where doctors talk to their patients, they're able to help navigate these complex systems, especially with expensive medications. So I think that interaction is really invaluable. And had that patient just simply been referred to a mail order pharmacy where they didn't get where they would have to pay to get their drug, they just would have not gotten their drug. So this interaction with the healthcare team becomes really critical so we can help patients navigate this complex environment.
Exactly, and I could not agree more. I mean, that's the additional hidden cost is all those patients that end up not taking a prescription that would alleviate their suffering or their discomfort, and in many cases, prevent them from getting well. So anyway, transparency's got to be at the root of all this stuff. Thank you. I yield back.
Thank you. Senator Warnock.
Thank you so very much, Senator Welch. Last week, I invited Lacey Mason from the state of Georgia as my special guest at the State of the Union speech. She is a type 1 diabetic. She needs insulin to survive. Even with insurance, insulin was too expensive for her to afford, and she had to resort to black market insulin in the United States and borrowing expired insulin from friends. She told the story about meeting people she didn't know. She met on Facebook in parking lots to get insulin. And while I'm glad that my proposal to cap insulin at $35 per month for Medicare beneficiaries is now law, the fight is not over. There are still too many Georgians who aren't able to afford the insulin they need to live. Dr. Trish, do you agree that prescription drug prices like insulin are too high?
So that's there's a lot to unpack in that question. I think that insulin is an example where, it's a prime example really, where the list prices are particularly high and they've really increased over time in ways that harm patients at the pharmacy counter. The research that we've done at the Schaefer Center shows that the net prices that manufacturers receive has actually declined, although the total amount that we're spending when you account for what the PBMs and other intermediaries are taking home has not declined, right? So this is an example where it depends what price you're asking about, but it's absolutely problematic for patients, yes.
So in a sense, while it was important for us to have this cap, you're pointing to the larger root cause and the issues around PBMs. So related to that, and you point out the drug pricing is complex. That said, it's no secret that pharmacy benefit managers or PBMs have played a role in high drug prices, and that's what we are examining in this hearing today. How are PBMs contributing to high list prices for drugs, especially for insulin?
Absolutely. So they're essentially, PBMs are in a position where they make more money as the list price goes up, as they get a percentage of the rebate or some other type of fee that's based on that increasing list price. And so you've seen, even though insulin is a very highly competitive drug class, there's multiple products that exist there, and the rebates are enormous, typically more than half of the list price. But nonetheless, the pressures and the incentives have made it so that when manufacturers have opted to offer lower priced drugs, PBMs won't put them on their formularies.
So they're incentivized to be bad actors in this space, costing people like Lacey, literally.
Particularly when those patients face cost sharing that's based on the list price of the drug, then that's absolutely problematic for them, yes.
I agree. I think Congress needs to address the role that PBM rebates play in high drug prices, and that's why I was proud to vote the Pharmacy Benefit Manager Transparency Act out of committee last year and look forward to supporting it again this year. Dr. Oftebro, I don't want to butcher your name. My last name is Warnock. I get called Warlock and all kinds of things.
That was perfect.
Is it uncommon for pharmacists to see folks come in unable to afford their medicine?
Senator Warnock,
Speaking of insulin.
Senator Warnock, we see that every day. The out-of-pocket costs for patients, there's no way that it's not a barrier, and it's forcing patients to make very difficult decisions, whether they take their medicine, whether they ration their medicine, whether they don't take it at all. But it's clearly an unbearable impact.
Yeah, and in fact, a recent article on NPR says that manufacturers have increased the price of insulin by more than 600% over the last 2 decades. 600%, a drug that was created 100 years ago, the patent was sold for $1. Do you believe this leads to rationing? You pointed that out, or finding other ways for patients to drag out how long the medicine will last or refill. What kind of effects does this have on patients' health? Because I think as we work on the policy, we have to center real people. What's the impact on the patient?
Well, when a patient isn't taking their medication as prescribed, there are all kinds of negative impacts, but they're ultimately deteriorating health. They're using the healthcare system inappropriately, more ER visits, and these have cost all of us at that point.
So it costs them more and it costs us more.
Correct.
So thank you so much. Look, hearings like this are incredibly important, so we can come together and work to get something done for our constituents. And everything we do on drug pricing, it seems to me we have to center the patients because they are the ones who are really caught in the middle, and I hope we can get some progress. Thank you for everything you do on this front.
Thank you. Senator Klobuchar.
Thank you. Dr. Trish, my bill with Senator Grassley, the Preserve Access to Affordable Generics and Biosimilars Act, passed out of the Judiciary Committee for a second time last week, and it would limit anti-competitive deals where brand name drug companies pay generic competitors to stay off the market. It's known as pay for delay, costing consumers millions of dollars, stifling competition. Do you think measures like this would help lower drug prices? And why is it important that we include biosimilars?
Absolutely. So I think it's very important to recognize, right? If you go back to the Hatch-Waxman Act, right, the idea here was to kind of preserve the incentives to produce innovative products, but with the expectation or return being that once those products went generic, they would be widely available at low cost and providing value to many Americans. And I think it's important that we ensure that we're delivering on the promise of that bipartisan legislation that worked so well for so long. I think some of the things that we have concerns about are whether PBMs are actually getting in the way of that kind of grand bargain working out for society by inflating the cost of generic drugs and other things like that when they do get to market and ultimately not delivering on the value when they become generic that we expect.
Another question. The House Oversight Committee recently found, as you know, I chair the Competition Policy and Antitrust Consumer Rights Subcommittee over in Judiciary, and House Oversight found in an investigation of high drug prices that drug companies use strategies to suppress competition and maintain monopoly pricing by pursuing contracts with PBMs and insurers that condition drug manufacturer rebates and price discounts on excluding competitor products from PBM and health plan formularies. Do branded drug manufacturers offer larger rebates to or force bundled contracts on PBMs in order to keep potential competitors off the market? And what effects do those contract terms have?
So it's certainly the case that as part of the negotiation between PBMs and manufacturers, the kind of goal of what PBMs are trying to pursue or extract value is to basically say, offer us a bigger discount or a lower price in exchange for us driving more volume toward your product rather than a competitor's product. I think when that works and when those savings are passed to consumers, that can be beneficial in driving value. But the issue is that when those savings or the benefits of that transaction or negotiation don't reach consumers, then we're not really getting the value that we're supposed to be out of these types of negotiations.
Okay, very good. Thank you. Next up, price transparency. Do you think we need more price transparency in the medication supply chain? I guess I'll ask you, Mr. Offbro, and thank you so much for your work. Could you answer that?
We absolutely need more transparency in the prescription drug price chain. We have no idea. I'm not only a pharmacist, I'm an employer. So I deal with these issues as an employer as well. And even as a pharmacist and understanding how the drug supply chain is supposed to work, it is so difficult for me as an employer to get the visibility into our own drug spend that we clearly have a problem.
Okay, thank you. Back to you, Dr. Trish. One issue that I have been working on for years, Senator Collins and I passed a major bill on this, is drug shortages and going to drug manufacturers in other countries when we have a shortage. Some of these shortages, as you know, are returned. What are PBMs and drug manufacturing doing to better anticipate and forecast demand for medicines and avoid shortages, and what do you think we should do?
So I think this is absolutely an important issue. You're starting to see, for example, new entrants into the market, like the Mark Cuban Cost Plus Drug Company. We've heard a lot about what they're doing on the PBM side, but they're actually also stepping in as a manufacturing plant to manufacture some of these drugs that are in short supply. I believe last I heard they were starting with sterile water, which is actually a very important part of the healthcare system that receives probably less attention than it should. So these are some of the ways that the market is stepping in to help, but I think that the issues that are created by the dynamics and the pressures that they're having throughout the supply chain are exactly the type of thing into which we need more insight.
All right, thank you very much.
Senator Rosen.
Well, thank you, Senator Welch. Appreciate that. We're really pleased that you're holding this important hearing today, because bringing down the high cost of prescription drugs, it is one of my top priorities for Nevadans from Ely to Pahrump, all across our state. And as we continue to build on the successes of the Inflation Reduction Act, including allowing Medicare to negotiate for the lowest price of prescription drugs and capping insulin costs for seniors at just $35 a month. I'm really glad to see that there's a commitment in this committee to work towards lowering prescription drug prices for everyone. And I want to continue along the lines of Senator Tester and Senator Sullivan on the impact of PBMs on rural and independent pharmacies, because they're just a critical lifeline for our rural Nevadans. And in my state, like so many others, independent pharmacies, well, they serve not only as access points for rural Nevadans to receive their prescription medication, but they often provide clinical services like blood pressure, glucose monitoring for those with high blood pressure and diabetes. Unfortunately, between 2003 and 2018, more than 1,200 independently owned rural pharmacies across this country have closed, including in Nevada. In fact, there are many communities in my state that have just one or no rural pharmacies remaining. And so one challenge is that prices for what should be cheap generic drugs end up being higher for these pharmacies than the larger chains. I've heard from independent pharmacies across my state and in Reno who are going to work every day to provide patients with life-saving medication. But as a result of the current prescription drug reimbursement ecosystem, they are struggling just to keep the lights on and serve the people that they care about in their communities. And so, Dr. Oftebro, you're based in Seattle, but like in my state of Nevada, Washington State, you have numerous rural communities. They've lost their independent pharmacies, due in part to the practices of PBMs. So what are you hearing from your fellow pharmacists in rural areas across your state about that pressure they feel from current dispensing reimbursement policies?
Thank you, Senator, for the question. You're absolutely right. Our independent community pharmacies in our rural communities are vital lifelines, and Washington State is no exception. We have pharmacies in rural areas. We have pharmacies on islands. A good colleague, Rick McCoy, is on Lopez Island in the San Juans, and he is the only pharmacy on the island, and he was able to provide thousands of COVID vaccines during the pandemic. And he's struggling, and you know, if he's not able to be there to provide for his community, people on the island are going to have to travel hours via ferry to get to the next closest pharmacy. So it's absolutely a crucial issue, and we need to ensure that these rural pharmacies, who are the only access point of healthcare for many communities, remain viable.
Thank you. And I want to build on that, thinking about rebates, because they're intended to lower costs for consumers, but the reality on the ground looks very different for far too many families, and especially Nevada families. And there's limited federal transparency in the rebate process. So it's hard to know how we can best ensure savings from rebates, that they're actually passed on to the consumer. So Dr. Trish, how can we ensure that rebate savings are actually passed on to the consumer in order to lower costs at the pharmacy counter? These are life-saving drugs. People need them, and we want to give them the best price.
Yeah, you're absolutely right. So I think all too often these rebates are not being shared at the pharmacy counter. We've done research showing the impact this has had, estimating that about half of Medicare Part D beneficiaries pay more out of pocket than they would have had rebates been shared with them at the pharmacy counter. Some of them about 20% on the order of more than $100 extra per year. Interestingly, it also has led to accelerated federal spending on the reinsurance program in Medicare Part D as well. So it has many, many different effects. I think there are policies that could encourage or promote sharing at the pharmacy counter with patients. But I think the other thing is, as we heard, there is a bit of a game of whack-a-mole here. And so as we've shined more of a light on rebates, there's now contracts that at least require more rebate sharing with the plans themselves, but that's led to other types of fees and offshore rebate aggregators and all these other things where it's hard to keep up and make sure that once we focus on something, it's not just going somewhere else. And that's where we need kind of true transparency and a true understanding of where the dollars are flowing across the board.
Well, I'm glad you brought that up. I don't have time for any more questions, but I do want to have some explanations on this rebate administration fee. And so we'll put that for the record, because again, these can be the way that people are shuffling these charges around, ultimately hurting the consumer. Thank you, Mr. Chair. I yield back.
Thank you, Senator Rosen. The hearing record will remain open for 3 weeks until March 9, 2023. Any senators who would like to submit questions for the record should do so in the next 2 weeks. That's by March 2nd, 2023. Witnesses, by the way, thank you so much for your testimony. We ask your responses be returned to the committee as quickly as possible, but no later than March 9. And that concludes today's hearing. Thank you very, very much.